Hi, great to be with you. I'm Doug Beal. I'm a private practitioner based in Oklahoma City, and I'd like to talk with you a little bit about patients with SI joint pain. So out of all the pain that we see, the back pain, a good portion of this will be SI joint pain. You probably know that it's between 15 and 22% of all back pain. So if you look at the Venn diagram on this, there would be a lot of overlap between hip, back, and spine pain and SI joint pain. And if we all think we can tell for sure what's coming from the hip versus the back, I think we haven't seen enough hip versus back pain. So the overlap has to do with the innervation, and it has to do with lots of other focuses and lots of other places where SI joint pain can radiate. It's typically located just below the PSIS in the back. Fortin's finger test identifies this, and that's the point of maximum tenderness. It's typically located there and radiates down the back of the leg and the back of the thigh. It can even give you a pseudo-radiculopathy radiating down the leg. And if you haven't seen this, it might have seen you. So this is one of the confusing components about SI joint pain, maybe probably one of the reasons why this is under-recognized and under-treated. So whenever we come to identify SI joint pain, you have to know that the 5-1 fusion, anything that is fused on 5-1, whether it be across that joint, whether it be a T10 to the ilium, whether it be a simple 5-1 fusion, and even I've seen numerous cases of long segment fusions with iliac bolts that were not sufficient enough to stabilize that joint. So anytime 5-1 is fused, we have to look for SI joint pain. Anytime the pelvic instability is suspected, we have to look for SI pain. Seronegative and positive spinal arthropathies, we have to make sure this SI joint pain that we see with these entities are not confusing us. These entities are primarily treated with DMARDs, disease-modifying anti-rheumatic drugs, not surgery, and not the typical injections and radiofrequency neurotomy. So once we've identified these and we can separate it out, SI joint versus inflammatory or infectious etiologies, we need to be able to identify the SI joint versus back or hip. So the SI joint is identified and clarified with this few certain number of techniques. So one is an injection test. If you inject the medication in and around the medial branch of the dorsal ramus from S1 to S3, and the pain goes down about 80%, which is the typical value that we use, then we're pretty sure that the pain is coming from the SI joint. But that's not the only method of identification. The other method of identification of SI joint pain is physical examination maneuvers. So we use various physical examination maneuvers, such as Gainsland's test, which is a torsional test of the pelvis versus the thigh. We also use the pelvic compression test, the pelvic distraction test. We use the sacral compression test. We use Patrick Faber's test, and we use the Fortin's finger test. So all of these in conjunction, if you have 3 of the positive physical examination tests combined with a positive injection test, that person, we have a very high degree of certainty that the pain is coming from the SI joint. So we combine this for treatment. We usually try rest analgesics, physical therapy, some of the conservative measures. If this isn't successful, then we go on for injections for therapeutic purposes. If the injections are successful but the duration of relief isn't long enough, we go on for radiofrequency rhizotomy. That typically lasts 6 months to a year. If the patient gets tired of doing the radiofrequency rhizotomies, or if the therapeutic efficacy wanes over time, then that patient's a great candidate for SI joint fusion. So once we identify the patient for SI joint fusion, then we have to identify the method of fusing it. We can go down the joint from posterior to anterior. We can go posterolaterally from the back part of the ilium, posterolaterally perpendicular to the SI joint. We could go direct lateral to medial and put a number of different devices, pieces of hardware in there, 2 to 3 typically per side. And these are the methods of fusing the SI joint. So the greatest amount of stability will depend on the condition that the patient has, and your goal, the treatment plan for the patient will depend on what they have, whether they have pelvic instability, whether they have degenerative spondylosis just based on degenerative arthritis from a 5-1 fusion. But identification of the patient, and based on the literature, if the patient is appropriate, we know from the literature that the treatment is very effective. On the average, we're able to get 50 to 70% reduction in pain. We're able to get at least 50% improvement in disability, and we know that that improvement is durable. It's been commonly tested at 2 years, but we know that it's been tested out to 6 years and more now. There's been 2 good randomized control trials. There's been 18 retrospective trials. There's been cohort match trials. There's been other review articles and meta-analyses. So there's lots of literature support for this. And we know that what we're doing that will not only be very effective, it's one of the most effective things that we do. We also know that it will be very durable. Thank you.